Hello everyone, and welcome to this comprehensive session on hyperthyroidism. Today we'll be diving into one of the most commonly encountered endocrine disorders, hyperthyroidism. ETs start with a simple definition. Hyperthyroidism refers to a condition where the thyroid gland produces too much of the hormones T3 and T4. These hormones play a crucial role in regulating our body's metabolism. When there's too much of them, the body enters a hypermetabolic state, meaning everything is sped up. Why should you care about this topic? Well, not only is it frequently tested in competitive exams like NEET, but understanding hyperthyroidism also lays the foundation for grasping broader concepts in physiology, pathology, and medicine. From weight loss and anxiety to heart issues and even eye problems, the symptoms of hyperthyroidism span nearly every system in the body. So let's unpack the thyroid gland itself before we go deeper into how and why things go wrong. Before we go into the pathology, it's essential to revisit the structure and function of the thyroid gland. Anatomically, it's that butterfly-shaped organ located at the front of your neck, just below the larynx and in front of the trachea. It has two lobes connected by a central isthmus. These lobes are filled with tiny sacs called follicles, and the walls of these follicles are lined by follicular cells. These are the cells that produce thyroid hormones, T3 and T4. T4, or thyroxine, is the prohormone. It's not very active on its own, but gets converted into T3, the active form, in various tissues like the liver and kidney. There's also another hormone, calcitonin, secreted by parafollicular or C cells. It regulates calcium levels but isn't directly involved in hyperthyroidism. The thyroid hormones, especially T3, regulate metabolism, heart rate, temperature, energy production, and even brain development. So any imbalance, especially excess, can affect everything from your digestion to your mood. Let's now look at how the thyroid gland is regulated. The hypothalamic-pituitary-thyroid axis, or HPT axis, is the central control system here. The hypothalamus releases TRH, which stimulates the anterior pituitary to release TSH, thyroid-stimulating hormone. TSH then acts on the thyroid gland to produce and release T3 and T4. This system works through negative feedback. When T3 and T4 levels are high, they signal the hypothalamus and pituitary to reduce TRH and TSH secretion, maintaining balance. In hyperthyroidism, this loop is disrupted. The thyroid continues to pump out excess T3 and T4, often suppressing TSH to undetectable levels, unless the root cause is a TSH-producing pituitary tumor, which is rare. This disrupted regulation is the root of most symptoms and complications, so understanding the axis is critical. Now, let's explore what actually causes hyperthyroidism. The number one cause, accounting for up to 80% of cases, is Graves' disease. This is an autoimmune disorder where the immune system produces antibodies called TSI, thyroid-stimulating immunoglobulins, that mimic TSH. These antibodies bind to the TSH receptors on thyroid cells and trick them into producing hormones nonstop. Graves' disease is also associated with goiter and eye symptoms like bulging eyes, called Graves' ophthalmopathy. Next, we have toxic multinodular goiter, or TMNG. Here, multiple nodules form in the thyroid, each functioning independently of TSH control. This is more common in older adults and in areas with iodine deficiency. Then there's toxic adenoma, also known as Plummer's disease. This involves a single nodule that becomes overactive and starts producing excess hormones. It's benign, but still causes a lot of trouble. Moving on to other causes, some cases of hyperthyroidism aren't due to overproduction, but rather due to hormone leakage from the gland. Subacute thyroiditis, for instance, is often triggered by a viral infection. It causes inflammation and the release of preformed hormones. It's painful and usually self-limiting. Then there's Hashimoto's thyroiditis. Interestingly, although it mostly causes hypothyroidism, it can have an early hyperthyroid phase called hashimotoxicosis, when the follicles break down and leak hormones. Postpartum thyroiditis is another transient form and occurs after childbirth. We also have iodine-induced hyperthyroidism, Jod-based phenomenon, especially in patients with pre-existing thyroid issues who suddenly consume excess iodine. And finally, there are rare cases like TSH-secreting pituitary adenomas, where the pituitary produces too much TSH, stimulating the thyroid inappropriately. Now let's talk about what actually happens in the body when there's too much thyroid hormone. This is where things start to heat up, literally. Thyroid hormones increase the basal metabolic rate, or BMR. This means your cells are working overtime. At a cellular level, they stimulate more sodium or potassium ATPase pumps, which consume more oxygen and generate heat, explaining the common symptom of heat intolerance. They also ramp up carbohydrate and lipid metabolism, leading to weight loss even though appetite is increased. There's increased protein turnover, which can cause muscle wasting despite high energy levels. Systemically, these hormones affect multiple organs. The heart works harder, resulting in a faster pulse, increased cardiac output, and sometimes arrhythmias. The nervous system becomes hyperexcitable, leading to tremors and anxiety. Even the gut speeds up, causing frequent bowel movements. So when we say hypermetabolic state, we mean your entire system is basically in overdrive. Now that we understand the physiology, the symptoms make a lot more sense. Let's break it down by systems. General and metabolic. One of the most telling signs is unexplained weight loss despite an increased appetite. Patients often feel hot all the time, sweat excessively, and feel drained or fatigued, even if they seem energetic. Cardiovascular. Expect to see palpitations, tachycardia, and sometimes arrhythmias, particularly atrial fibrillation in older patients. These symptoms should always prompt a thyroid check. Neurological and psychiatric. The nervous system is revved up, leading to tremors, nervousness, irritability, anxiety, and insomnia. These signs are often mistaken for psychiatric disorders unless carefully evaluated. Gastrointestinal. Patients might report increased bowel movements or diarrhea, not due to infection but due to increased gut motility driven by thyroid hormones. Continuing with the symptom profile. Musculoskeletal. A classic sign is proximal muscle weakness, like trouble getting up from a chair or climbing stairs. Over time, long-standing hyperthyroidism can cause osteoporosis, making bones fragile. Dermatological. The skin often becomes warm, smooth, and moist. Hair becomes fine and brittle, and there can be hair loss. Onycholysis, or nail lifting, is another subtle but telling clue. Ocular signs, especially important in Graves' disease, include exophthalmos or bulging eyes due to inflammation behind the eye. This can cause double vision, eye irritation, and a visible stare. You may also notice lid lag or lid retraction, hallmarks during clinical examination. Finally, the thyroid gland itself is usually enlarged, forming a goiter, either diffuse in Graves' disease or nodular in conditions like toxic adenoma or multinodular goiter. When hyperthyroidism is suspected based on clinical signs, we confirm it through thyroid function tests or TFTs. First, we check TSH. In primary hyperthyroidism, TSH is typically low or undetectable because the pituitary senses the high thyroid hormone levels and shuts off TSH production. If TSH is high, that suggests a pituitary problem like a TSH-secreting adenoma. Next, we look at free T3 and T4, the unbound forms that actually enter tissues. In hyperthyroidism, these are usually elevated. Sometimes only T3 is elevated, a condition known as T3 toxicosis. We also use antibody tests, especially for Graves' disease. The key ones are TSI or TRAb, which confirm the autoimmune cause. TPO and thyroglobulin antibodies may be seen in autoimmune thyroid disease, but aren't specific for hyperthyroidism alone. So, diagnosis is a combination of clinical features, hormone levels, and antibody tests. Once we know a patient has hyperthyroidism, the next step is to determine the cause. This is where imaging plays a key role. A radioactive iodine uptake, RAIU, test and scan is the gold standard here. The patient swallows a small dose of radioactive iodine, and we measure how much the thyroid absorbs. If the uptake is high and diffuse, it points to Graves' disease. If it's high but patchy or nodular, we suspect toxic adenoma or multinodular goiter. If uptake is low, it usually means thyroiditis or exogenous thyroid hormone use, where hormone levels are high not because of increased production, but due to leakage or intake. We can also do a thyroid ultrasound, which helps identify nodules, their size, vascularity, and whether they are solid or cystic. This is also essential before any biopsy or surgery. Hyperthyroidism is not just about symptoms. It can lead to serious complications if left untreated. The most dangerous is a thyroid storm. This is a medical emergency where everything goes into overdrive. The patient presents with very high fever, severe tachycardia, agitation, confusion, or even coma. It can be triggered by infections, surgery, or suddenly stopping medications. Without immediate treatment, it can be fatal. Cardiac complications are also common. The most frequent is atrial fibrillation, an irregular, rapid heartbeat that increases the risk of stroke. Over time, the heart can wear out, leading to high-output heart failure. Another long-term issue is osteoporosis. Thyroid hormones accelerate bone turnover, meaning bones get broken down faster than they are rebuilt. This increases the risk of fractures, especially in older patients. In Graves' disease, we must not forget eye involvement. If untreated, Graves' ophthalmopathy can lead to vision loss, dryness, corneal ulcers, or even disfigurement. Fortunately, hyperthyroidism is very treatable, and we have multiple strategies to manage it. The first line is usually antithyroid medications, particularly methimazole or propylthiouracil, PTU. These block the production of thyroid hormones. PTU also inhibits the conversion of T4 to the more active T3 in the periphery. They're often used as a bridge to definitive therapy, like surgery or radioactive iodine. But keep in mind, they can cause side effects, rare but serious ones like agranulocytosis, a dangerous drop in white blood cells, liver problems, and rashes. Next is radioactive iodine therapy, or RAI. It's a definitive, non-surgical treatment where the patient swallows iodine-131, which destroys overactive thyroid tissue selectively. This is the preferred treatment in many cases of Graves' disease and toxic nodular goiter. However, it's not suitable for pregnant or breastfeeding women and can sometimes worsen eye symptoms in Graves. Patients often develop hypothyroidism after RAI, which is managed with lifelong thyroid hormone replacement. Another option is thyroid surgery, usually a thyroidectomy, either partial or total removal. It's considered when the goiter is large, causing compression of nearby structures, or when there's suspicion of cancer, or if the patient cannot tolerate medications or RAI. The main risks include damage to the recurrent laryngeal nerve, which can cause voice changes, and hypoparathyroidism, leading to low calcium levels. After total thyroidectomy, patients will need lifelong thyroid hormone replacement. We also use beta blockers like propranolol to control symptoms. These drugs do not treat the thyroid problem itself, but they offer rapid relief from symptoms like palpitations, tremors, and anxiety. Propranolol has the added benefit of reducing peripheral T4 to T3 conversion, which is especially helpful in thyroid storm or acute cases. So, the treatment plan is usually tailored to the individual depending on the cause, severity, age, and preferences. For those preparing for NEET or other competitive exams, here are some high-yield points to remember. The active hormone is T3, while T4 is the prohormone. Know the hypothalamic-pituitary-thyroid axis and how negative feedback works. In primary hyperthyroidism, you'll see low TSH and high free T3/T4. Graves' disease is the most common cause. It's autoimmune, involves TSI antibodies, and presents with diffuse goiter and exophthalmos. RAIU scan helps differentiate causes. High uptake suggests Graves' or nodular disease. Low uptake points to thyroiditis or hormone overdose. Thyroid storm is a life-threatening emergency. Look out for fever, tachycardia, and altered mental status. Treatments include methimazole, PTU, RAI, and thyroidectomy. Don't forget complications like AFib, osteoporosis, and Graves' ophthalmopathy. These are commonly tested in MCQs and clinical case questions, so make sure you've got them down. To wrap up, hyperthyroidism is a condition where the thyroid gland goes into overdrive, producing excess hormones that affect almost every system in the body. It can stem from autoimmune causes like Graves' disease, structural issues like nodular goiter, or even inflammation from thyroiditis. Understanding the HPT axis, the mechanisms behind hormone regulation, and the symptom profile is crucial, not just for exams but for real-life clinical reasoning. Diagnosis hinges on TFTs, antibodies, and imaging studies like RAIU and ultrasound. Treatment options are diverse, ranging from medications to definitive therapies like RAI and surgery. Complications, especially thyroid storm, AFib, and bone loss, highlight why timely intervention is essential. Thank you for your attention. Now I'd love to hear your questions if you have any. Like, share, and subscribe for more videos.